I will be focusing on the niche area of complications of myocardial infarction. When you look at the role of echo in myocardial infarction, you're primarily looking at the wall motion, presence or absence of wall motion. How many segments are involved? More segments, worse it is. Is it hypokinetic? Is it akinetic? More akinesia, more worse the prognosis. And also you're looking at LV function. Is the ejection fraction normal? Is it abnormal? Those with ejection fraction less have a higher mortality, morbidity. So they go into a risk category. You're going to classify that. And diastolic dysfunction. Is it mild, moderate, severe diastolic dysfunction? Because they have independent prediction of what is going to happen. So that is a separate entity altogether. What I will be focusing upon are these conditions. Mechanical complications. So the mechanical complications, you have the papillary muscle rupture, the ventricular septal rupture, the pseudoaneurysms, the free wall rupture. These are the ones with lethal consequences. So they have to be identified in time, and echo is the tool which is really available to you. You can't get in a CT or an MRI into the CCU and try to find or detect certain things. So you are the key to finding what is the problem of the hemodynamics, the abnormality which is occurring. In addition to that, you have the RVMI, the infarct extension, and then to a lesser extent the pericardial effusion, and also the true aneurysms and thrombus, which are late sequelae. Let's start with the first one, the papillary muscle rupture. This is a story of a lady 60 years, so 60 plus, diabetic hypertensive, who had a single vessel disease and minor disease in the other two vessels, a single disease of the LAD. She underwent a CABG and she was doing well. She was on medications, she went back, and then she was walking, she was quite happy and everything had settled into a routine. But suddenly, prior to coming to us 2 days earlier, she had developed some symptoms of chest pain and breathlessness, which was a little alarming at first, and then it continued to persist on the second day, and that's when she felt really, really alarmed, because she felt those symptoms were similar to what she had earlier, and then she came. And she was found to have murmur, and then she was mildly breathless, and she underwent an echo. And you can see that this is a zoomed up view. Here, the LV seems to be quite good. It's a mildly hypertrophied LV going by the appearance, contracting well. And there is a shining area here, the posterior mitral annular calcification, that's age related. LA doesn't look that dilated. And you can see some amount of floppiness here. So this is was the first finding that something was not really normal here. And going to the short axis, you can look at the short axis here. This is the anterolateral papillary muscle. This is the posteromedial papillary muscle. Between these two, this is the most vulnerable because it has got only one supply, which is the LAD. So this is better off. The RCA, this is the opposite. The posteromedial is the one which is most vulnerable because it has the RCA which is supplying, and then you have the anterolateral which is supplied both by the LAD as well as the circumflex. So you have a dual supply for the anterolateral, and this is better off. But in this patient, you can see that the anterolateral papillary muscle here has got an additional floppy area, which is sort of a muscle which is bobbing up and down. So this is the first clue that this papillary muscle is involved, and then there is some amount of rupture which must have happened. Going to the apical fourth chamber, again a zoomed up view, you find that there is a discontinuity here. So this is a very clear case of one of the papillary muscle heads which has ruptured here and which has still got a continuity. It is not entirely fully ruptured, it's not entirely flail, and this in turn will cause malcoaptation of the anterior mitral leaflet, and this will cause mitral regurgitation. And this is the mitral regurgitation which you see. This is an eccentric MR, lot of MR coming in. The LA and LV are basically not ready to accept this amount of regurgitation which happens, and this is where the left atrial pressure goes up and patient becomes breathless, and the whole problem starts here as far as symptoms are concerned. So you'll have to look at the presence of MR, what is the severity of the MR, and this eccentric MR is the one which gives you a clue most of the times as to that there is something wrong with the leaflets, and which in turn you will have to find out what is the mechanism of what is causing this MR. So here is a clear case of rupture of the anterolateral papillary muscle. Initially, I was trying to find out and I was not really observant, and I was wondering why this has happened. But on closer examination, you'll find that the lateral wall is not contracting so well. It's a very subtle sort of finding. Usually in the rupture of papillary muscles, you'll find that it will be a small area which has infarcted and which can be very easily missed. So whenever you find a patient with papillary muscle rupture, try to look for these areas of hyperkinesia or akinesia. So this part was affected here. This is a still image, and this is a complete rupture of the papillary muscle, and this is a T which I have taken from another colleague here. And here you can see that the MR is very torrential. It just pours into the LA, and this in turn causes a sudden increase in left atrial pressure, pulmonary edema, hypertension. Patient can go into sudden hemodynamic compromise and can die very fast. So this is the complete rupture of the papillary muscle. Now, looking at the anatomy here, the papillary muscle rupture, if it is right at the base here, the entire trunk, it is catastrophic. Usually the progress is very fast and death occurs if there's no intervention which is occurring immediately. But these patients who have one head which gets ruptured, they are the ones who survive, and then who come to you and you have time, and then they live depending upon how good the LV is. If it is of good LV systolic function, if the ejection fraction is reasonably maintained, they tend to live longer, and that is if there is no intervention, and the survival is much better. And again, it depends on the severity of the MR. So papillary muscle rupture, you will have to look at whether it is partial, whether it is complete. If it is partial, which head is it coming from? Is it from the anterolateral? Is it from the posteromedial? If it is from the posteromedial, you know that the consequences are much worse. The other complication is ventricular septal rupture. Here you have an incidence of less than 1%, and most of the time these patients have a background of being of older age, they are females, non-smoker. That means their collaterals are not well developed and they're vulnerable to developing septal rupture. And their prognosis and their progress depends upon the size of the defect. So bigger the size, more will be the shunt, and more severe will be the hemodynamic deterioration, and the survival will be less. So looking at certain patients here, starting from transthoracic echo, this is a patient with anti-wall MI, and ventricular septal ruptures can be either close to the apex or can be at the lower part of it, the basal septum. And these are generally small, whenever there are small ruptures, the traditional, the apical four-chamber view may not be able to detect it. Here you can see that it looks intact, but the clue is that there is something wrong here. There's some turbulence which you are seeing here, and there's some amount of TR. So here what I have done is I've gone a little out of the view. This is like an off-axis view. It's neither four-chamber, it's some weird funny view, but what is important is that you're able to see the area where the rupture has occurred, and this is important, and this is what you have to establish and identify. So the message here is that ventricular septal ruptures can be very tiny, and you have to go off-axis, and you will have to look at where the rupture has occurred and focus upon that. Not just the apical four-chamber, you will have to look at even the apex. So multiple views are important. So this is the apical view. You can see that this is the LV and this is the RV, and a clear passage which has occurred between the LV and the RV. So this is apical short axis. So make it a point to look at the LV, the septum from multiple views, and this is the turbulence which you see here, that is where the shunt is occurring. This 3D picture shows you how well contracting these segments are, and then here you can see that there is acute thinning here. So here there is thinning, and at this point there's been a lot of damage here which has necrosed and the tissue has just given away. So there's acute thinning here, and this is where the rupture has occurred. So it is important that you also look at the segments here and try to identify where exactly the hinge point is between the normal and the abnormal area. So that's where the rupture usually tends to occur. You can have different types of ventricular septal rupture. What I showed was a simple rupture, and they're also classified as complex ruptures. In complex rupture, you can have multiple passages here. So here is a patient with anterior MI, and you can see that it is there are multiple passages here. You can find one big passage where the flow is occurring, and then it's almost sieve-like here. So this is a complex ventricular septal rupture. So identification of septal rupture and trying to document whether it is a simple or complex. So this will be important for any interventions later on and for prognosis. And again, this same patient seen from apical fourth chamber, you can find that the passage, the opening here has it's very clearly seen, and you can find that it's again that spongy appearance of the ventricular septum. And again, from the apical short axis, you can find that this is the passage here. Now we had a look at anterior wall MIs. So this is inferior wall MI. And inferior wall MIs, you will have rupture which will happen at the base. Again, note the apical fourth chamber. It's not the usual classical fourth chamber of what you are always trying to acquire, make it as vertical as possible, and avoid the foreshortening. So you have to go a little off axis. And once you go off axis, you tend to see it much better, and this is where the rupture has occurred. And once you identify the rupture, it is also important, especially in the inferior wall MIs, the basal ruptures, to look at additional associated findings. So here you have mitral regurgitation. So it is important that you document and look for mitral regurgitation. Presence of mitral regurgitation along with ventricular septal rupture makes the prognosis even worse. And more the MR, more the prognosis being bad. And again, it is also for intervention. So for the surgeon, if he wants to intervene, whether mitral valve replacement is necessary or not, this will depend on the presence or absence of MR. Now, this is another patient with inferior wall MI. Here you find that the LV is briskly contracting and very grossly distorted RV, dilated RV. So it looks as though that there is some amount of significant akinesia, definitely the RV is involved here. The two-chamber view is fairly glaring. There's no way anybody can miss this. Initially I thought it looked almost like a pseudoaneurysm. There is no continuity here, and the neck, though not that narrow, it did give the appearance of the inferior wall being involved and the RV being involved. And whenever the RV and inferior wall are involved, it's always going to be the proximal RCA. And here it looked like a pseudoaneurysm. So again, with this suspicion, I continue to investigate. And then in the short axis, this was seen at one particular angle. You will see that there is a flow which is going into the RV. Now suddenly I had to reconsider, and I was thinking whether this is a ventricular septal rupture, because there is a clear flow which is going into the RV here. And again, this is without color here. Then I had to do a little bit of off-axis views. So at this point, you can see a little bit of the RV here, and this is the LV here. So this sort of reasonably established that it is more of ventricular septal rupture rather than being post-basal pseudoaneurysm here, and this is very clearly seen here. So this was the conclusion at the final diagnosis. There was some discussion whether there were a couple of colleagues who felt otherwise. Then I was looking at the literature, and then I came across this case report. Case reports do have a lot of value. Fortunately, many of the journals these days are not really much into case reports. So this particular case report had a similar experience, but they also had they had acquired images in the 3D. So their initial impression was infrabasal pseudoaneurysm, but looking at multiple sections, the conclusion was that this was more of a septal rupture. So many times, going back into the literature, looking at case reports do help in some of these difficult cases. So as far as ventricular septal ruptures are concerned, you will have to go a little out of the way. You have to go off axis. You have to be quite alert, and many times what you see may not be what you are actually thinking, and it can create an illusion. So be careful about what you see and how you conclude. Once you've established the presence and absence and the location of ventricular septal ruptures, we have to look at the hemodynamics. So in terms of the LV-RV gradient. So you have a flow which is going from left ventricle to the right ventricle, and one needs to find out what is the RV systolic pressure here. When it is in the apex, it's difficult to align the Doppler cursor, and then it can be problematic, and many times you may not be able to really get a peak systolic, good accurate peak systolic gradient of the VSD. And you can see that this is a non-parallel, and then you will see flow from both sides. So you can try a subcostal, and if it still doesn't work and you're still keen on knowing what is happening to the RV pressures, the TR will give you the severity of the pulmonary hypertension. So it is important to document what is the status of right-sided pressures and what is the status of the pulmonary pressures. In addition to that, one has to also assess RV function. So RV function assessment is also important in terms of prognosis. So you can use either the TAPSE, putting an M mode sample here, or you can use the tissue Doppler. So here you'll see that 10 is the cutoff which is suggested with the latest guidelines. Anything less than 10, if you're putting a sample here, that means the RV function is reduced. So you have to document the presence or absence of RV dysfunction. The other thing is you also have to look at what is the magnitude of the shunt. So here you have to go through the shunt calculation. You can start with the diameter at the LVOT, the parcel long axis. Usually the zoom view is better. And once you get it, you measure the diameter here, and then the machine does the calculation. It gives you the area through this cavity. Then you go to the high parcel short axis, and you get the pulmonary valve, that is the RVOT measurement here, and this will give you the area across the RVOT. So you have LVOT area, RVOT area. And then you put a sample at the LVOT, a pulse wave Doppler, and then a pulse wave Doppler at the RVOT, and then this gives you the shunt. So if the images are good, you're able to get good the QPQS, the shunt ratio here. So anything more than 2, again it is something which is not good for the patient. So structural detection, hemodynamics in terms of looking at the PA pressures and the shunt calculation. So this would be the basis for looking at the ventricular septal rupture as a whole. Now, beyond the detection, what really happens next? So these are images which have been provided by my anesthesia colleagues, the cardiac anesthesiologists from the OT. This is what happens in the OT if the patients are taken for surgery, and you find that there is a clear rupture here at this point. So the images are inverted. So this is, those who are not familiar with transesophageal echoes, the whole thing gets inverted here, and you have the LV here, the RV here, and this is the basal septum, and you see a flow here. And again, this is transgastric, and you see this turbulence here. and that again indicates that there is a point where that shunt is occurring, where the defect is. And this is the post-operative image wherein the patch has been placed. There are different techniques, and depending on what the surgeon wants to do, and this is a successful one, a good outcome, a happy outcome for the patient, wherein you find that there is no shunt which is detected post-operatively. Another patient, that one was at the basal septum. This is at the apex. You find that again it's a large area, and you can see the flow here. This is again deep transgastric, and good outcome again in this patient, where you find that there are it's now well and truly closed, nothing at all. But not all patients have successful outcomes post-operatively. If there is a patient who has been operated for ventricular septal rupture, it is important to find out whether there is any residual shunt. So here is a case which things didn't go well for this particular patient. A patch was put, and then it's given way here. So you find that there is a shunt which has occurred, and again this is important to document, and then there's not much the surgeon can do at this point, and it is just documenting. And then in this particular case, he said just wait and watch, and there's nothing much to do. The patient stabilized and then was discharged. And again, you can see the track here. The patch comes here from this point to this point. They attach it here and then to a healthy area. At some point, if it is not done at the right place, or if the infarct has extended a little more because it's still in acute stage, the patch might give way, and this is where the track has occurred. This is another patient wherein you can see that this is the patch, the pericardial patch which has been put here. It has given way here. So this patient did not have a successful outcome, and this patient died post-operatively. So there are some good outcomes, bad outcomes, but generally the surgeries are high risk, and there's very little option, and the stories vary from patient to patient depending on their background. Now let's look at another complication, pseudoaneurysm. So pseudoaneurysm, typically if you look at the picture here, have total loss of discontinuity. You have the myocardium here, and there is an abrupt cutoff. There is no myocardial continuity here at all. So it's a clear through and through cut through the myocardium here. And look at, this is the neck of the aneurysm. So it's a very narrow neck what you see here. And what you see on this image is a large pseudoaneurysm, and this is the neck of the aneurysm. So there are some calculations based on you're looking at the diameter of the neck here, and then the diameter of the aneurysm, and if it is around 0.25, if you take the ratio 0.25 to 0.5, it is supposed to be a pseudoaneurysm. So the main thing is, wider the neck, more likely it is to be a true aneurysm. Narrower the neck, more likely it is to be a pseudoaneurysm. Pseudoaneurysms are nothing but contained ruptures. It has ruptured, but what has happened here is the pericardium has caused some adhesions, and it is closed and contained it. And this can continue to be like this, or it can give way anytime. So these are patients at very high risk of sudden death, and intervention has to be considered, and these are patients who have to be categorized as high risk. This is in the short axis, and you see again the through and through rupture here. And once you put on the color, you'll find that there is a to and fro color back and forth as the flow goes into the chamber here and then goes out. So this is another way of establishing that it is pseudoaneurysm. So you have to establish that there is a narrow neck here, and then put on the color and look at the flow and see whether the flow goes back and forth. Free wall rupture. Again, this patient I was called to the CCU, had sudden vomiting, and then started deteriorating very rapidly. So here you can see that there is, the first thing that I saw was the pericardial effusion, and immediately I knew that there was a high likelihood of a rupture. And you can see that it's very obvious here, which is given way here. So even as we were discussing, and then we are trying to plan what should be the mode, and we were trying to organize things. And when we diagnosed it as a free wall rupture, the patient progressively deteriorated, and within a matter of minutes, the patient died. So this was a patient with not a good outcome. So what is important is that if you see an effusion and if you see something which is moving up and down and which has got a clear cut through and through, and where the blood is sort of seeped all around, there'll be a lot of tamponade and then pressure, and then patient rapidly deteriorates. This patient was another one, a luckier patient, wherein a free wall rupture has occurred. There's a clot inside it, and this clot basically acts as a seal and sort of prevents further drainage of the blood from the chamber into the pericardial sac, and sort of acts as a protective lining here. This is more like a subacute sort of a presentation. He was a fortunate patient, went for surgery, and this is how it looks on surgery. So they opened up, and this was how the clot was looking. So you can see, there's so much of blood clotting, it keeps coming out, and it's quite a sight to see something like this. And more or less, most of the clots were taken out at this point. And once the surgeon removed the clot, then his next task is to find out where exactly the ruptures occurred, and this is where the rupture has occurred here. And once the rupture has occurred, so then he has to close this. So there are again various techniques. So he has taken a pericardial patch, and then he used some Gore-Tex sutures here, and then he put the patch, and then the rent, the opening which was there, was closed, and you can see that it is a beating heart. And then once the rent was closed and it was a successful closure, this is the echo. So these are good stories, and these are, when it happens with good outcomes, it's really nice to look at it. So the intervention is very important, the support, the backup is also important. So again here, free wall ruptures, pericardial effusion, presence of clot, and identification of where the rupture is, and if there is immediate backup, it can be very helpful in determining the survival of the patient. The other complication is right ventricular myocardial infarction. Any patient with inferior wall MI, always make it a point to look at the RV free wall. It has to be a routine, and if there is an RV MI, this is how it looks like. You'll find that the RV is akinetic here, and then you have to establish the RV dysfunction here. And once you have done the RV function assessment, you also have to look at what is the TR, what is the amount of TR. And this again is important in the follow-up of the patient, whether the RV function is improving, whether the TR is worsening. So any inferior wall MIs, do make it a point to look at the RV, and if there is an RV involvement is there, you have to quantify the RV function, normal or dysfunctional, and then whether there is presence and absence of TR, and what is the severity of the TR. The other complication that can happen to a lesser extent is pericardial effusion. Pericarditis is pretty common in some set of patients, and they usually have chest pain, but in a small segment of patients you can have a presence of pericardial effusion. So if you do find pericardial effusion, document it and inform, because if the patient is on anticoagulants, the heparin, so that has to be stopped. And again, the location of the pericardial effusion and sizing of it, how much it is, where it is, whether it is posterior, and what is the thickness of the pericardial effusion, that has to be documented. Now, coming to the last few slides, true aneurysms. The pseudoaneurysm you saw, there is a discontinuity, a narrow neck. While you look at the true aneurysm, it has got a wide neck here. So this is how it looks like, and then there's this outward bulge which has happened. And again, you might have to go a little off axis to get a true picture, true image of the aneurysm here. So again, the point here is wide neck, and then you have this bulge here, thinning here, an intact continuity of the scar tissue here that establishes that it is a true aneurysm. Now, aneurysms can be in different places. So here you have an aneurysm at the basal posterior wall, and it can be quite dramatic at times. You can have a very large aneurysm here, and aneurysm always look for the presence or absence of the thrombus inside. And here you can see that whatever is coming, the flow which is coming from the left atrium, most of it is going here, and the cardiac output in this patient will be very low, and this is where the aneurysm has to be closed, and the aneurysmectomy is to be done in such patients where the facilities are there. So this is a true aneurysm, a very large aneurysm of the posterior wall. And if there is a surgery which has been done, there is something called as a Dawes procedure. They put in a patch. This is an endoventricular patch which closes off this cavity part here, which is not contributing anything. So they try to sort of make it into a much more smaller ventricle and more effective, efficient ventricle here. So here you can see that this is the patch which is seen. Somewhere here it's given up a little bit, so you find a small tiny flow here, and this is a classic example of a Dawes procedure where the aneurysm, which is not contributing anything, is separated off from the rest of the ventricle and to increase the cardiac output here. And the last, the complication which I'll be looking at is any patient with acute MI, use your gain. Usually we talk about optimizing gain. So here, if you overgain it, you're likely to detect the presence of spontaneous echo contrast. So any place, any segment, especially the LV apex, if you see akinesia, always there should be a high suspicion that a clot is likely to form. And you see the smoke here, so this is the spontaneous echo contrast here. So this is another patient here with a lot of sec, and again akinesia here, and possibly a clot has started to form here. And again, this detection can be done if there is contrast. They can get a more confirmatory finding. If you put in a contrast and this appears as a dark layer, then you know that it is contrast. But again here, akinesia, sec, high likelihood of a thrombus being present. Now, you can have a thrombus actually forming. And again, what is the type of thrombus which you see? When you have an echogenic thrombus, which is looking a lot more brighter, not so mobile, and it has got a surface which is more uniform. That means like this thrombus has been there for a longer period and is unlikely to embolize. But whenever you see a thrombus like this, just about barely seen, the echogenicity is much less when you compare it to this, and it's more mobile. And if you put in a zoom, you're more likely to see some irregularity. This sort of a clot is more likely to embolize. So you have to identify presence or absence of clot, and if the clot is there, is it an organized one? And more organized, less likely to embolize. And if it is mobile and if it is less echogenic, this is more likely to embolize. So this differentiation has to be there. And whenever there is an aneurysm, again, there's a small aneurysmal sort of sac which is beginning to form here, always look for a clot. There should be a high degree of suspicion when you see an akinetic area and when there is an aneurysm. Now, finding a clot is all fine. This is a very gross one, very obvious one. And using the 9 slice here, one can section the clot here at different points. And you can see here that there are two small clots here which are dangling sort of, these are clots which are likely to embolize. And these sort of patients have to be aggressively treated, and it has to be brought to the attention of the clinician, and the anticoagulation has to be very aggressive and has to be followed up quite fast. So don't just be carried away by seeing the clot. Do look at it from multiple angles. If you do have the bigger, the better machines with more sophisticated software, well and good, but make it a point to look at it from multiple angles and see that you cover as much of area as possible, and then try to define the clot in every context. So in conclusion, what are the complications of myocardial infarction? You have cardiogenic shock here that is related to the LV function, which I have not gone into. That's a separate chapter altogether. Basically, I've looked at mechanical complications. You have free wall rupture, the interventricular septal rupture, the MRs. These are the ones which have catastrophic and acute issues, and they have to be identified quite fast. And my last slide is just to look at the differentiating features here. So if you look at the incidence, they're all very small percentage of patients. They all occur within a matter of a week. Presentations are more or less same, though there can be slight variable presentations if you really look at it in a very sort of minute way, but generally they have chest pain and shortness of breath. Physical findings can be variable. Some of the, if it is very obvious, well and good. But ultimately what I'm trying to tell you is, it is echo which is able to detect and then to differentiate if there is a complication, what sort of complication. So it can clearly tell us if it is ventricular septal rupture, or if it is a rupture of the ventricular free wall, or if there is papillary muscle rupture, and if there is papillary muscle, is it a complete rupture or is it a partial rupture. So I think this would be my final message, and I will close with this.
Thank you very much.